Thank you, esteemed speakers and the chairpersons. And with that, we will move on to our next session. And our next session is about EPO in heart failure. And this session is sponsored by unrestricted academic grants from Sun Pharmaceutical Industries Limited. Can we have ADK? And for this session, may I please request Dr. S.K. Parashar, Dr. S.K. Chopra, Dr. R.J. Manjuran, Dr. P.K. Dave, Dr. R. Alagation, Dr. P.S. Banerjee, Dr. Soumitra Roy, Dr. A.S.N. Routledge, Dr. Sunit Banerjee to join this session as chairperson. And our first speaker for this session is Dr. Thomas Binder, and he will present his case on any paradox in new guidelines of diastolic dysfunction. Requesting all the speakers and the chairpersons kindly restrict their presentation and discussion by the stipulated time, otherwise the time for discussion will be over to the chairperson and the first presenter, Dr. Thomas Binder.
I think without wasting much time, we'll directly go to Dr. Binder because diastolic dysfunction itself is a very, very important subject also. So let us see what suspense he has for us. So Dr. Binder first to discuss on the various aspects of a diastolic dysfunction, the paradox. Tom,
Thank you very
please.
much. Thank you very much, Dr. Parashar, for this very kind introduction. I will maybe try to be a little bit provocative this time and maybe try to challenge some of the notions that have traditionally been made with respect to diastolic dysfunction, and maybe just not so much talk about the paradox of diastolic dysfunction. Many of the things that we've been using traditionally for many, many years is still applicable. And in this respect, I think I'm actually pretty much aligned with the guidelines that have taken back some of the older notions, and I would say maybe even started to rethink the subject of diastolic dysfunction a little bit at least. Maybe I can push this forward and discuss where we might should go to a different route. Well, when you go back to this whole issue of diastolic dysfunction, there is very difficult to say where all of this discussion started. But I guess it was the observation that there are a number of patients, and we know that, who have dyspnea, but who have a normal ejection fraction. This was actually the starting point many, many, many years, before we came to the understanding of some of the modern things in diastology. Now, the route that we took was obviously led by many publications and by subjects discussing the importance of E to E prime and maybe pulmonic vein venous flow and further, and many other things. But I think what we're now coming to is to a point where we're, I think, almost stuck a little bit in a dead end. And what we're confronted with is, I would call, an escalation of commitment to a losing course of action. What am I meaning with this? Well, what I'm trying to say here is that we've put so much effort and so much studies and so much time and so much of our, I would say, teaching into this whole issue of diastolic dysfunction that at some point is very, very difficult to maybe rethink the whole topic again and maybe start from the beginning with the knowledge we have at hand and maybe make it more simple. I want to just start with a very simple case to illustrate what I'm trying to show here. Now, this is a patient, I'll need to reloop this here, with case of heart failure with preserved ejection fraction. I guess all of you will agree that this patient has a very small ventricle, that there's left ventricular hypertrophy, and this patient has dyspnea. Yeah, the left atrium is large. So quite frankly, this is a patient where it's not surprising that, that there is dyspnea. And if you look at the filling pattern, it's restrictive. So this is
Dr. Slide
also,
moving.
We can't see your slide.
Yeah,
Slides are not moving.
Slide. We can't see
Uh-huh.
your slide.
this one is not supposed to be moving, but
no, you have to share the screen first to get the slides. Because none of the slides are visible.
okay, you're not visible at all.
Yeah, now,
No,
now it is visible.
Now it's fine.
Now it's visible.
Okay, let me try to share it once more to see, because now, okay,
Go to full screen. Go to full screen.
okay.
You have
Slide
to go
show.
to slide present. Okay, fine, great.
Can you
Fine.
see them now?
Yeah,
Yeah.
that's better.
Okay, but let me do one thing, then I think this will make it easier. Give me just a second here. Okay, I think this should work now. Is it moving?
It's
No.
not moving.
Not moving.
Not moving?
You
No.
have to make the whole screen full screen, I think then.
Okay, let me
You
try
can
one
see the
more
next
thing.
slide.
Give me just a second.
Ah, yeah. Just click.
Okay, you can see it here moving, right?
Yeah, now it's
Yeah.
moving. Yeah.
This is not full screen, but anyway, I think I'll just stick
That
it
will
with
do.
here, and then
That will.
But anyway, what I'm trying to show here is a patient with a rather small ventricle with left ventricular hypertrophy, older lady with hypertensive heart disease and with dyspnea. So it's quite clear that this patient must have some degree of, I would say, diastolic dysfunction, or let's call it heart failure with preserved ejection fraction. If you look at the Doppler across the mitral valve, it's quite clear that there's restrictive filling patterns. So we are assuming that there is elevated filling pressures here. And if you look at the Doppler, we can see that the patient also has pulmonary hypertension. The velocity we have here is 3.6 meters per second. So that is quite high. Now, all of this fits quite nicely. And we're probably prone to say that this patient has a clear case of heart failure with preserved ejection fraction, which in essence is true. But if you look at the following loop, which is this one here, you'll realize that this patient might have a normal ejection fraction, but this is definitely not normal systolic function. Why? Because we have a clear reduction in longitudinal strain. So what we're seeing here is a small ventricle with good ejection fraction, but that does not really reflect systolic function. So this is not diastolic heart failure. This is in reality systolic heart failure. You might call it subclinical systolic heart failure. And if you go now to this slide here, and I hope you can see this, this is basically the percentage of patients with different degrees of left ventricular dysfunction measured by strain in a subset of patients with heart failure with preserved ejection fraction. And you see that a large number of patients, the majority of patients who we are classifying as heart failure with preserved ejection fraction actually have systolic heart failure, period. I think this is a notion we need to understand. It's something that is very, very important, but which unfortunately has not really sickled down into the group of those who are really writing the guidelines and those who are really trying to decipher the whole issue of heart failure with preserved ejection fraction. The bottom line is, and I can already start with a conclusion slide. My first conclusion slide here is diastolic dysfunction is not an isolated phenomenon, but it is strongly coupled to systolic function. So we cannot really separate the two in reality. And heart failure is heart failure, and we probably should stop trying to decipher what is diastolic, what is systolic. There's been a very, very good editorial many years ago by a colleague called Sanderson, and he made a very important notions of how the link between systolic and diastolic heart failure is and how we are not really able to discern these two. It's an integral part of cardiac function. Both of them are. Like I said, most patients with diastolic dysfunction also have systolic dysfunction. So we have to ask ourselves, how common is isolated diastolic function? Is it something that we see frequently? Is it only something that we see in patients who have some form of distension of the increase in ventricular size, where the elastic properties of the ventricle is somehow disturbed? Or is it not that practically if you have diastolic heart failure, you must also have systolic heart failure? And if you have systolic heart failure, you must also have diastolic heart failure. Now, coming back to this patient, this is the E to E prime. And not to a surprise, what we see in this specific situation, we see a relatively small E prime wave. The E to E ratio is 26. So it's quite obvious this patient must have high filling pressures. But I must ask, do we even need this information in the setting?
Thomas,
Remember,
Tom, your slide is not moving.
okay,
Yeah.
can you see it now?
Yeah.
I'll just leave it like this. What I'm trying to say is that the question that I'm trying to raise here is that E to E is not really necessary in this clinical situation as we see it in this patient, simply because we already have the pulmonary pressure, we already have the restrictive filling pattern. So the filling pressure here was quite clear to start out with. And just to show you another example, this is a patient who has hypertensive heart disease, okay, where we have normal, relatively normal longitudinal function. We have significant LVH, we have good ejection fraction. And then if I use the pulse wave Doppler, not to surprise, we have impaired relaxation, something we see very frequently in LVH, especially if it's to a degree where we have at least moderate LVH. So again, in this situation, with a normal function, with normal strain, and with only impaired relaxation, E to E prime is probably, redundant. It will not add much information because we know that this patient has normal function. So if we leave out the tissue Doppler, I think that we can probably solve 95% of all cases, that we can probably make the diagnosis without the sophisticated modalities that are so highly proposed. And I'm not only talking about E to E prime, but also about maybe the filling pressures we assess with pulmonary vein flow and many other of these modalities that some of them actually have now been abandoned in echocardiography, flow propagation, for example. So if you look at these patients, this is obviously the one with the normal function and the normal filling pressure. While obviously this patient will have a problem because we have a large left atrium, because we have a patient with LVH. And this is a patient with dilated cardiomyopathy. Remember, all patients with systolic heart failure must have some degree of diastolic heart failure. And this is another patient with hypertensive heart disease with severe LVH, which almost looks like amyloid heart disease. So in reality, in most clinical situations, but just by putting the transducer on the chest, you will already be able to estimate or at least determine whether or not the patient has elevated filling pressures. So the second conclusion I'm trying to make here is that Doppler parameters provide little additional information to what can be assumed based on 2D echo and clinical information. I must say tissue Doppler parameters here. This is just a typo. So, so now we've got it much simpler than we had at the beginning. 2D echo and pulse wave Doppler is the mainstay, and this tells us so much information. But let's go back a step and let's discuss if we do use E to E prime, does it really work? Here's an example. Here's a patient with massive LVH, okay? Hypertensive patient, I've treated him for many, many years. He's had probably 25 years of high, very difficult to adjust blood pressure. Now here's the Doppler signal. You see that the E is higher than the A. It's not impaired relaxation. Formally, we'd call this pseudo-normalization. And what we expect here is that we have an add-on information if we use the tissue Doppler, in the sense that here we would actually expect the filling pressures to be high. But based on the tissue Doppler here, we don't get really much information. It looks like this patient has normal filling pressures. if you look at the E/E ratio. But then we performed a cath study and the patient definitely had elevated filling pressures and he was symptomatic too. So in reality, this is actually leading us off and not helping us very much in our decision making. And there's been numerous studies that have looked into the correlation of E/E prime and invasive parameters. And yes, there is a certain correlation, I would say, but look at the correlation. It's sometimes as low as 0.19. The best we have here is maybe 0.84. And if you use an aggregate value, you see that the correlation is rather poor. It's only 0.56. And I don't know how many of you have performed cath studies in such patients. You will frequently find that these values are not correct. And this is something that has been shown also in these studies here. And even if you look at the E/E prime and you correlate them with major cardiovascular events and try to use this as a predictor, you will see that in reality, it's not very good. The hazard ratio is 1.05, which is not very high. So in reality, E/E prime is simply not a good parameter. It's based on a few very good assumptions, but in clinical practice, it is just simply off. It is off much too often. So diastolic dysfunction, filling pressures cannot be assessed reliably with echocardiography. Yes, we can estimate them. Yes, we can have a certain feeling for what they are. But we have to look at several parameters together, and there's not one single parameter we can use that will really tell us what the problem is. And then we've got another problem. If we use E/E prime, we've got just so many different scenarios where E/E prime cannot be used. And if you look at the guidelines, you will see all of these. It's the patients with the high heart rates. It's atrial fibrillation where you have, a big scatter in your results. You've got atrial stunning, a situation that you will frequently find after you perform atrial arrhythmia ablation. Mitral anocalcification, mitral valve prosthesis, even regional wall motion abnormalities are a reason. So there's so many different reasons where you cannot really use it. Pacemakers, and even in transplantation, you will see that you will have patients who have normal transplants, but still you will have small E/E ratios, and even the E/A ratio does not really hold in transplant patients. So there's so many limitations that where you cannot use it. And this is another limitation. Now, if you go to the guidelines, and this is the flow chart that is published in the guidelines, in a way they are already, I would say, making a U-turn in the sense of not giving E/E prime and any of the other parameters as much emphasis as before, because there were so many patients who were simply classified falsely. And they use a certain weighing where you have three criteria, which is the E/E prime, you've got the TR velocity and the left atrial volume index. And then you kind of say, okay, how many of these parameters are positive, how many are negative? And then you come to a conclusion whether or not the patients have diastolic dysfunction or not. And the reality is that infrequently you will have a situation where you cannot say, because one is positive, one is negative, and the other one cannot be assessed. So at the end of the day, you will end up with many patients where you do not really know what the true answer is. So based on the current guidelines, a large number of patients will remain unclassified if you use the criteria. So you might even ask yourself, well, who cares about diastolic function in the first place? So what me worry? What importance does it really have in clinical practice? Well, yes, of course, it does have value. And you all know these patients where you have cardiomyopathy and you have a restrictive filling pattern, then you give the patient treatment and he reverses to maybe an impaired relaxation. So you can monitor the patients, and it does correlate quite nicely in symptoms in this patient group. But in reality, in many situations, you have a patient with diastolic heart failure, or call it heart failure with preserved ejection fraction. You have a disease where there is no treatment. You see the number of studies that have been performed, in not only in heart failure, but also in not only in HFpEF, but also in HF and REF patients. There's numerous studies, but especially for heart failure with preserved ejection fraction, we still do not have a drug. We don't have anything we can really offer. So how does it really help us in this patient class? The treatment that we can help the patients with are those that treat the underlying problem, if there is one. And that's what we should be doing anyway. regardless of whether or not the patient has impaired relaxation or restrictive filling pattern or whatever. It's treatment of obesity, hypertension. Of course, in many situations, we can't do anything as in aging and so forth and so on. So I think the bottom line, I think, is that since there is no specific treatment for diastolic dysfunction at present, and the group that we're observing here is so inhomogeneous, we maybe are wasting too much time in diastology and not really helping our patients. So I believe it's maybe time to rethink diastolic dysfunction and also HFpEF. I think that we need to start again and look at what the problem really is here. We're just throwing all sorts of different diseases into one single bag, and then we are surprised why no treatment really works. The treatment cannot work because we're not treating disease, we're treating an echo parameter or some other parameter that has been defined by the guidelines. So I think we need to also define the role of echocardiography. And maybe just to simplify these things, this is my take here. I think the elevated filling pressure is something that is the consequence of a stiff heart, which we can usually see or observe on the 2D echo with the help of pulse wave Doppler and with the history of the patient. Elevated filling pressures occur in systolic dysfunction, no matter if it is ejection fraction reduction or longitudinal function reduction or both. And that, let us not forget that the atrium also plays an important role in the cause of elevated filling pressure. So maybe we can just start on new grounds and maybe rethink some of the things that we've been using for so many years. Thank you for your attention.
Thank you, Dr. Binder, for a very exhaustive discussion. I'm afraid that we don't have time for discussion on this very thought-provoking talk because there are a lot of other issues.
Unfortunately, yes, Sumitra, unfortunately, I think your point is correct, but I think this particular talk needed so much of discussion because that was a very controversial talk or so. He has completely condemned diastolic heart failure. Now, one of the criteria for diagnosis of a heart failure with a preserved ejection fraction is to demonstrate an increased filling pressure. Either you demonstrate by invasively by mean LA or LV pressure or E/E prime ratio. Now, if you see the 2020 guidelines, which we follow now of a Mayo Clinic, they have taken the same 4 parameters and in a single algorithm, they have defined a diastolic dysfunction is present or not, filling pressure is increased or not, and what is the type of diastolic dysfunction in a single sort of a thing. And if we go on GLS only, then I think the incidence of a diastolic heart failure will be significantly decreased than what is reported in the literature.
Just
So
one question, Dr. Binder. I think Dr. Parashar has just mentioned. Do you think that E prime ratio has no value in prognostication or therapeutic implication at all, besides the limitation which you enumerated?
I think that there is very few cases where it really helps you. In 90% of patients, as I've shown, you can probably already estimate, or let's see, you can suspect elevated filling pressures. There you might or might not find the parameters of E to E prime. I think they're also affected by many other factors, and that there are, as literature has shown, it's just not a good parameter. I think we should stop using it. I know I'm very provocative here. But
Dr. Chopra has said that in literature, E of E prime has been referred as one of the prognostic factors besides deceleration time and many other factors or so. So I think according to you, when the next guidelines of the diastolic dysfunction comes, E oblique prime may be removed or so.
I just want one more clarification, sir. The answer is E by E prime ratio along with the atrial dysfunction will enhance the potential of E by E prime ratio.
Can you repeat the question?
If we take E by E prime ratio along with assessment of atrial dysfunction and combine together,
I think that will definitely help us to understand why the E to E prime ratio in many situations does not work. I think we don't really understand fully what the role of the atrium is. I think maybe atrial strain will help us to understand this topic more. I think that there is probably also an effect of longitudinal function, systolic longitudinal function on E to E prime. And there's probably many factors we don't even know yet that play a role. I know I'm very provocative here. Of course, this is something that would need, I think, discussion. I think it's so important that we sit back again and maybe look at some of these things again. But honestly, I don't think that this is something that is going to be used very, very much in the future. And I see that when I talk to some of the colleagues.
May I
I
take
think
part,
this-
sir,
I-
Mr. Professor?
I think
sir,
the next
sir,
talk
sir,
by
please.
Chandrasekharan
Yeah,
may give
please.
something.
Yeah, left
Yes,
ventricular filling.
yeah.
And the next
Yeah.
talk. Yes.
Sir,
Next talk.
one thing
As
is
you are
that,
running short of time, sir, we have already overstood the time.
just one question, will you allow Aniruddha?
Well, you
Short-
can do one
Short
question.
question.
Yes,
Oh,
sir.
it's very
please.
short,
Yes, sir.
It appears that you do not believe in the existence of diastolic dysfunction without coexisting systolic dysfunction. Is it true?
I think that there is not many cases where you have classic diastolic dysfunction without systolic dysfunction. That's my belief. Yes.
But then
we-
the hypertrophic cardiomyopathy is an exception where there is a super systolic function and there is significant diastolic dysfunction.
I
No,
think
sir, if you
even-
go by the GLS, of course, the hypertrophic cardiomyopathy GLS will be less.
Yeah.
Yes, I think there's any form of hypertrophy will in some form, at least if it gets to a certain point, also affect systolic function. And
I think let
hypertrophic
us go to
cardiomyopathy is such an example.
Thank you very much for creating something in our mind which will think over for some more time and give you one more chance to talk after 6 months as to what your current view. But I
But
think
this is-
Chandrasekharan must be very keen to talk now as to whether evaluating the LV filling pressure is the need of the hour. So let us see what Chandra has to say.
I'm
Chandra,
very
please.
happy that I was able to stimulate the discussion. This was exactly the objective.
I think certainly it's a very controversial topic, especially Dr. Binder. I think you've created you're trying to U-turn totally, which is going to be a little bit difficult. I got to tell you. Well, I think.
Yeah, you
Oh,
are
good.
audible and visible.
Can you hear me?
Yeah.
Yes, you are audible and visible.
Very good. I think the key to define the heart failure is we need to know whether the LV is able to fill all the content without elevating the pressure. And similarly, is it able to empty all its content without increasing the contents are expelled without any further strain. So to meet the demand completely, these are the two essential parts. I think people have a wrong concept that if you look at the LV diastolic dysfunction or LV diastolic function analysis, it is a complex interaction between LA, LV, and we just take LA and LV alone. On top of that, there's also RV and pericardium. So if you look at that, this is a LV pressure. Simply, the progress has done in such a manner that we have recognized the gradient between the LV and LA can be assessed using the pulse Doppler, which everybody agrees there's no controversy. And based on that, we have developed Dr. Hartley's work and so many other pioneers who have done the work clearly pointed out that E-wave morphology adds more information about the transmittal of the blood flow from the left atrium to left ventricle and the force with which it comes and the force with which it decelerates. All of them adds to the characteristics of the ventricle as well as the function of the myocardium. So we measure the E-wave, A-wave, EA ratio, and deceleration time. Then we want to know the property of the myocardium. In general, during the myocardial relaxation, if the myocardium is healthy, during the early relaxation, you have a E prime, and during the late A prime. This E prime is usually robust, is greater than 8 to 9 or 10 centimeters. And this has been well accepted by everybody. Now, people have shown as early as 1997 that as the ventricle changes, I do agree with Dr. Binder that yes, everybody, there's no question of differentiation between systolic and diastolic. But I think he's also have a different opinion about GLS alone. I do beg to differ from him that GLS alone is not the measure of systolic function. If you're going to be a purist about this systolic dysfunction, you don't need to measure the cardiac output, systolic stroke volume, and also the aortic impedance. Combination of that is going to be the way, not only GS alone. But if you look at it here, people have clearly shown that as the ventricle remodels LVH, whatever the disease process that occurs, E wave becomes less robust in terms of deceleration. And as the LA pressure increases to empty the volume, then the E wave again changes. So this clearly shows that the E and the E prime are interrelated. And one of the biggest mistakes that we all make is that thinking that when you do a bedside echo or echo in your lab, that is the gold standard for the diastole. No, it is not, because it is a dynamic nature. So you do need to know what is the patient's symptom and when do that occur, and you need to provoke that type of activity and look at your diastology. Then you will be clear what happens to the E wave, what happens to the E prime. Then you can assess the filling pressure. So in other words, I think the diastolic filling pressures, mitral E wave and E prime, EE, this has been well validated for a long time by Sharif Nage and Steve Aumann from our institution, that CAT correlation, anybody who's got an EE prime ratio greater than 15 have an elevated filling pressure. This is given that they are done at rest. Let's say that if this is done with the ambulatory or this is done with a supine bicycle reproducing the symptom, I would say that this correlation is going to be far better. So if you look at it here, normal E wave, I do agree with Dr. Bender that there are several permutations can occur. You can have a normal E wave, normal E prime, then the E ratio is normal. So in majority of the patients, they're going to have normal filling pressure if they don't have any symptoms. If they have symptoms, this and this can vary. Depending upon the patient's symptom, even though they may have it at rest like this, it is very rare that they're going to have a normal E prime at rest if they're going to have any significant cardiovascular symptoms, either shortness of breath or any comorbidities such as hypertension or diabetes or ischemic heart disease or anything, then the E prime is going to be very rarely going to be normal. But on the other hand, in patients with constrictive pericarditis, they can have a normal E prime. And a younger age people, even with comorbidities, sometimes it can be normal. So if you combine the E velocity and the E prime, this E prime ratio can give rise to several permutations which one has to take into consideration. Just because at rest they look one, it doesn't necessarily mean that they're going to be the same. So it is going to depend on heart rate, blood pressure, posture of the patient, supine versus standing, respiration, volume status. One of the cases they were presenting that they could not be able to find out the constriction. If the patient was able to stand up, JO has clearly shown from an institution that when the filling pressures are very high, if you can decrease it by making them stand up, then the constrictive physiology comes out very nicely. So all these things plays a role. When such a thing is playing a role on LV filling pressure, just taking it at rest where this and this are constant doesn't make any sense. Here is a patient who has got hypertrophic cardiomyopathy and mild mitral regurgitation and grade 1, maybe grade 1A in our pattern, doesn't matter. So E prime, E and A reversed and E prime is low and basically normal filling pressure. So this patient now presents recurrent pulmonary edema. Why would she come with recurrent pulmonary edema? Either blood pressure should be going up or she must be exerting. So when she came, made her walk up one flight of staircase from downstairs to upstairs. So when she did that, look at here. And look at here. MR increased. Look at the E prime. E velocity increased significantly from here to here. Just a simple less than 3 minutes to 5 minutes walk from 10 flights of staircase climbing up. Just let's bring up here, say, oh doctor, I can't do that at all. Let's see how many steps can you walk, I'll come with you. So then we do that and come and do the echo. Look at this. This is what it is. We can't just base our assessment at one point in time. This is a dynamic one. And this patient goes to the cath. And look at here. She does a supine bicycle exercise. LV-EDP is low. Here it's increased. Look at this corresponding. So invasive studies, when it is done simultaneously, both in the case of constrictive pericarditis, which we used to do for a long time before, and with aortic stenosis, Phil Curry and Darrell Breslau have shown what mitral processes. In every case, when you do a simultaneous cath and hemodynamics with Doppler, they correlate quite well. When it is not done simultaneously, yes, of course, there are going to be discrepancies. Those discrepancies are due to volume factor, heart rate, blood pressure, afterload, etc. So here is another patient, basically has hypertension and exertional dyspnea, no ischemia, at resting, LVH, LV function is good. I do agree that I think this abnormal myocardium is going to have a abnormal E velocity. And look at E velocity, the grade 1 diastolic dysfunction, E prime is 7. So E ratio is basically 7 with normal filling pressure at rest. Now, this patient, we put her on a supine bicycle. Look at here. Just based on this, look at the E prime, how it changes. E velocity, not E prime, E velocity. So here, I think people can look at it here. E prime ratio increases, goes to models about 15, and TR velocity increases. So this brings this changing the morphology, where your LA pressure has to go high up to drive the blood across the LV, clearly shows that it is not a simple dynamic, simple resting one phase. It is a constantly changing phenomenon. So one has to use that in mind when we are trying to look at assess the LV filling pressure. And here, look at this, LV EDP of 12, with the supine bicycle, when it corresponds, our EDP goes very high. So this clearly points out that LV EDP, LV pressure, where E prime ratio clearly gives an insight non-invasively to us, is a dynamic phenomena. We can't just base it on one finding, what we find at the echo lab when they are at rest. You need to reproduce the symptom of the patient, then try to do it, then it will have better correlation. So the take-home message is E velocity definitely reflects myocardial relaxation. It does not change much with exercise. So when the myocardium is diseased, E prime is going to be reduced. I do agree. When they're going to be mitral annular calcification, mitral fibrosis, all of them, yes, it's going to be difficult. So those kind of cases are not the cases where we're going to get into trouble, where they invariably we have other methods. Then E prime ratio estimate the LV pressure at rest as well as with activity. So I think utilizing bedside maneuvers to reproduce the symptoms at the time of echo will give you a better judgment or better guidance for what the patient's filling pressure will be at the time of the symptom, and it will correlate better with the catheterization. Thank you.
So I think Dr. Chandrasekhar, as you had a very nice presentation, that any patient who is a vulnerable hemodynamics or variable dynamics we can predict by E prime ratio. It's very clear. So we can prognosticate patient and we can have a therapeutic implication, which we do every now and then. And I think a lot of patients coming to us in our echo lab have a highly vulnerable hemodynamics. I think that's a very nice message.
And
Dr.
in
Chopra,
fact,
can I
No,
make a
it is-
comment?
in fact, if you
in-
see,
in-
as Chandra has pointed out, simultaneous studies have been done, both at invasive hemodynamic with exercise plus a routine echo. Both of them have been done simultaneously, and some of the studies have found a good correlation between the two studies also. So I think we cannot 100% condemn E prime ratio, but still it will carry some significance in certain situations where it has got some clinical or the other value or in these situations also.
Can I make a comment, sir?
Yeah.
Yeah. So I think what Dr. Chandra and Dr. Binder said, they were all important things. I do agree with Dr. Binder is that the E by E prime, the present diastolic dysfunction guidelines has a lot of fallacies. But I think we have to understand that HFpEF is a disease spectrum where there are phenotypes. It can either be because of cardiac problem per se or non-cardiac per se. So what I feel is that E by E prime is important, but if we look at the E prime only, if the E prime is reduced, then we are looking at directly a problem involving the left ventricle. Now there is a role, and there are a lot of work. Sanjeev Shah's group. I'm sure Dr. Binder must be knowing that we have to have an exercise parameter and also look at the left atrium. And E by E prime is a more dynamic process, and it gives a lot of information on a day-to-day basis for patients' symptomatic relief. So the E by E prime is elevated, you can give them some diuretics and something, but it is a very dynamic process. I'm sure what Dr. Binder has given us the thought that we need a lot of changes in the present diastolic parameter assessment, and I think we will be looking forward to an addition of left atrium and the exercise parameters.
I think at the end of the day, when you have a patient, you're not going to treat the echo, you're going to treat the patient's symptom. So you are really going to find out what the patient's symptom is and whatever that is needed to corroborate or refute and then use that. I think I'm not trying to say that, see, echo is evolving, but what we have to keep in our mind is that there are certain proven facts which are there. We can't just disregard the proven facts. We can clarify the proven facts and we can make them feel better. Now, certainly left atrial emptying and left atrial strain is going to add to the armamentarium of diastology. I do agree with you. Heart failure with preserved ejection fraction is a very conundrum, basically. But on the other hand, the reality is Ramachandran in 2000 has published heart failure with preserved ejection fraction, irrespective of what it is. Their outcome is as bad as heart failure with preserved reduced ejection fraction. The etiology is basically cardiomyopathy, hypertension, or diabetes, or whatever it is, doesn't matter. See, our point is you can't disregard something which is at hand. When a patient comes to my office saying that I'm short of breath, I just don't know what it is. Your E prime is normal. Maybe you may have constriction, but you don't have a constriction. You can go. No, just do what brings a symptom and use that. I'm not trying to say that we don't have a 100%. If everything is very clear, medicine won't be what it is. We have evolved. Where is CT scan? When I went into medical school, there was no CT scan. Now CT can do so many. The echo was basically was nothing there. So it was just a A-mode echo. Now where it is. So we have to use it. We can't just condemn it what it is, but we have to use it and better refine it.
So to collaborate what you say, because this diastolic stress echo has come up in a very big way, because many persons complain of breathlessness only on exertion. And one of the criteria of a positivity is increase in the E/E prime ratio. So that
Yeah.
is besides other criteria of the positivity of the diastolic stress test. One of them is E/E prime ratio.
Yeah. So I
So I
think
think let us see how it goes over the next 6 months. Possibly Dr. Binder may turn out to be correct. And if you see the January issue of the JACC cardiovascular imaging of 2020, there is a discussion between JO and Nishimura. Both of them have tried to contradict each other and support each other. So I think that article is very worth reading as to what should be the new guidelines for diastolic dysfunction.
Maybe just one final word, because I think, maybe to bring this all together. What I'm here also a little bit for is an advocate for those millions of doctors out there who are practicing echocardiography, maybe not such super experts that they really understand everything, and they're confused. They're absolutely confused because they don't know how to apply the guidelines. And because I think that we should give them a simple way that they can at least go about. And I am 100% with Dr. Chandra that yes, the whole issue of exercise and diastology, there's much more to know. There's much more we can do. And I still think that there is a certain group of patients where the E prime might play a role if you want to go into more advanced features and look at the problem into more details. But I think, we have
thank you very
Okay.
But thank you very much. Now we can come to the next talk. Yeah, we can come to the next talk because we are very short of time.
Okay.
Okay.
I will go to the next talk. The speaker is Dr. K. Rekhu. He's our president of the Indian Academy of Echocardiography. From diastology, we are going to systology. And he's going to talk to us about LV function beyond ejection fraction echocardiographic approach. For many years, or for time from the echocardiography came into regular clinical use, we have been always using ejection fraction as the parameter of LV function. And many recommendations are based on ejection fraction. Let us learn from Rekhu how these new parameters help us and how does it correlate with the previous ones, which is based on ejection fraction. Rekhu, the floor is yours.
Thank you. It's my slides visible?
Yeah, your slide is visible.
Yeah. After that fascinating discussion earlier, where Dr. Binder led the cat among the pigeons and Dr. Chandra did his best to save as many pigeons as possible, mine hopefully will be a more sedate talk. For times immemorial, ejection fraction has been regarded as the holy grail of echocardiography. And we have often believed that evaluation of echo means evaluation of the ejection fraction. Echocardiography actually helps a great deal in evaluating systolic function by diagnosing the problem, risk stratification, therapeutic guidance, and assessment of response to therapy. You look at a number of things like chamber function, the hemodynamics, myocardial function, interactions too. Now, I'll just start with a simple case. This 46-year-old lady came to me with significant congestive heart failure, though she had no PND. She had significant elevation of the JVP and her pedal edema. The ECG and echo done elsewhere were normal. I'll just play a few echoes. You will notice that the LV function is normal, even the grayscale through the color. But what is impressive is that there is a great deal of turbulence at all the valves. And a study of our hemodynamics showed that the cardiac output was significantly raised. These are the aortic velocities and the mitral velocities. Though the filling velocity seems normal, the E by E prime was not elevated. When we did an assessment of the stroke volume, her cardiac output was more than 7.5. And an assessment of a thyroid function showed that T3 was markedly elevated, as was the T4, and the TSH was almost undetectable. So we treated her for thyrotoxicosis, and her symptoms completely eased, her congestive heart failure decreased. So assessment of the LV function includes stroke volume, the DPP-DT, and the tissue Doppler. I will not dwell on these things much in the interest of time because we are running short of time. The organizers are already on tenterhooks. DP by DT is a very useful evaluation. There's a mitral regurgitation, but I think most of us have given it up. This is an instance where the ejection fraction and the DP by DT correlated. The DP by DT was less than 700. The normal values are more than 1,300. Myocardial performance index is another thing that can often be looked at. It's a very easy to do. It can be done in multiple ways using tissue Doppler or your regular Doppler or even an mode echo. So nobody can claim that they cannot do it just because they don't have the right machine to do it with. And it has its own uses because it prognosticates, just like E by E prime has been shown in some studies to prognosticate. Even tie a tie of more than 0.7 to 8 has been shown to have adverse events and greater mortality in patients with congestive heart failure. Now, 3D is another thing that is being increasingly used. You can use to assess the regional and segmental volumes. See, it also helps in making out the different areas of contractility. This is an example of a 3D done in our lab where to see the curve summating the normal patient. On the right side of the patient, LBBB, there is a marked dysynchrony in the volumes of each part of the segment. Now, this is a patient who came to me with an acute myocardial infarction. If you notice the grayscale, there isn't much of a dyskinesia observed in the echo, but the 3D shows a significant apical dyskinesia. So 3D has become increasingly used to assess the structural abnormalities in echocardiography. LV systolic function by tissue Doppler imaging came into being in the first part of this century. It has been increasingly replaced now by strain imaging. Tissue Doppler still retains its value, as you heard Dr. Chandra say, that it's very useful in diastolic function, but even in systolic function, it can show abnormalities in patients who have a reduced ejection fraction. And there has been any number of literature which has shown a good correlation. Now, it has been used to assess cardiac discipline. Here again, strain is slowly replacing it. Here you see a parametric measurement where these curves are made, and this is a patient where there is a lateral wall delay. So tissue Doppler can be used for CRT assessment also. Strain is now the thing that has come into increasing force, and that is what has lent so much credence to what Dr. Binder said, that there is no diastolic dysfunction without systolic dysfunction. And I'll just go to support it in some of these patients. This is a 58-year-old male who attended our health camp. His echocardiographer's initial impression was, is he having a very borderline AV function? He is normotensive, non-diabetic, and a non-smoker with no previous MI, and he had no ECG changes. He never had chest pain, in fact. He was asymptomatic at that stage. This echo, you can see the echo for yourself. The LV contractility looks at best about 50 to 55%, and there is no gross LVH or anything of the sort. There was more mitral regurgitation. However, what bothered me at that time was that he seemed to have a monophasic diastolic wave, and also his E prime was reduced. So when I did a strain analysis, something bothered me, so I went ahead and did a strain analysis because it's the initial part of our strain learning curve. It was on a Philips machine, and I didn't get the bullseye chart in that particular thing. But nevertheless, you can see some apical sparing, and his MRI also goes to show that this was a cardiac amyloid. We proved it both with cardiac amyloid and a rectal biopsy. And I sent him across to an oncologist who took him up for a stem cell therapy. And after 6 years after the diagnosis, he is still alive and doing well. This young boy was diagnosed to have a myocarditis about a year ago. And then he came asymptomatic, wanting to know whether he could stop all his medications. He was on Ramipril and also on beta blocker. Now, looking at the grayscale images, you know that you can think that his EF is around 60%. So what do you advise? When I did this strain in this patient, there was a significant abnormality in some of the segments. Some of the curves you notice do not reach the baseline. So I could easily advise the boy that he needs to continue his cardiac medication for some more time. Now, this lady, age 62, underwent treatment for breast CA. The baseline strain prior to the start of chemo showed almost normal strains with an average of the global longitudinal strain being about 19%. And when I did a year later, after she had completed a course of chemotherapy, the strain had mildly decreased. It decreased to more than 15%. And I probably would not advocate for the use of chemotherapy if it were required. And I happened to follow her up for nearly 4 years. The strain did not appreciably increase, though the ejection fraction was always normal. Now, this patient was a 58-year-old lady, diabetic hypertensive, She presented to another hospital with prolonged chest pain of 2 hours duration. Her serial ECG showed non-diagnostic ST changes. Tropi after 6 hours was normal. Echocardiogram was normal. Her ECG did not show any great changes to suggest ischemia. Her echo, grayscale echo, 2D echo was reasonably normal. There was no evidence, there was no evidence in the echo of any wall motion abnormality. I'll just let it run for your benefit. I'm sorry if I cut it off in the middle. As you can see, the fourth chamber also does not show any wall motion abnormality, nor does the two chamber. So I went ahead and did a strain analysis on her, and the strain was definitely abnormal in certain of the territories, the basal lateral wall and the posterior wall. Then we did a coronary angio for her, and that showed a mid-segment total occlusion of the left circumference. This 38-year-old male, diabetic and hypertensive, had recurrent episodes of chest pain and presentation blood pressure of 160/100. His blood biochemistry was normal, the ECG was normal, and the troponin was not assessed. Here again, if you notice, there are no wall motion abnormalities, and all the three segments are relatively normal. So when I did a strain, the basal segments were markedly reduced. If you notice the curves, the basal segments were distinctly lower. He underwent a treadmill after some 2 hours since he was not immediately agreeable at the time for an angiogram, and that showed significant ST abnormalities towards the end of stage 1 of Cruise. So longitudinal strain definitely predicts predicts the presence of left main coronary artery disease or even arteriovenous disease. And in this study, they concluded that strain at first was significantly lower in patients with left main or triple cell disease without RWMA, and will be useful in identifying patients with severe CA. Now, I happen to do 1 or 2 cases of DSC with strain. This is an example of a baseline strain that was normal and a peak systolic strain that was abnormal. It's not very easy to do it because it's not very reproducible. The high heart rates make it very difficult to do it. You might have to use metoprolol to reduce the heart rate to do the strain. This very busy slide I've included only to show you that with strain, you can classify the patients to even further subgroups, which might help in making out the prognosis of the patient on treatment or modify the treatment strategies. Now, why is it important that we move from EF to better technologies? If you notice in this curve, the EF is a very good indicator of prognosis and mortality as long as it is above 35%, but below 35%. Once it comes into the mid-range of 35 to 50, it hardly prognosticates. But you see the right chart, you notice that at every level of EF above 35, adding global longitudinal strain adds to your prognostic value and also your therapeutic value. This again, very busy slide. I'm not going to go into the detail. Now I'll just add that the further mechanisms of testing LV function are twist and torsion and velocity vector imaging. Unfortunately, though, velocity vector imaging and twist interaction have been there for more than a decade now. There are not many takers, not many users, and longitudinal strain is the one which is taken over. Having assessed other methods, I just want to express to my juniors not to forget the LV as a composite thing, not just look at diastolic and systolic function. This is a patient of dilated cardiomyopathy. You can just call it a dilated cardiomyopathy and get away with it. But if you look at it carefully, there is marked thinning of the basal anterior septum and the basal inferior septum. So this is not a vascular distribution. So this case was a proven granulomatous myocarditis. We use both PET and a biopsy to prove sarcoid in this case. So with this, I close my talk with stating that assessment of left systolic function has a central role in the evaluation of cardiac disease. Strain echocardiography performed by using speckle tracking technique can identify subclinical LV dysfunction. Many of your diastolic dysfunctions are possibly subclinical LV dysfunction. Strain echocardiography is a powerful predictor of cardiac mortality and morbidity, and current imaging guidelines recommend routine echocardiographic assessment of strain for follow-up of oncology patients after chemotherapy. Thank you.
Thank you, Raghu, for giving such such an elaborate description, especially focusing on LV strain, longitudinal strain.